All right. Uh, Thank you all for joining us this evening for NAMI Northern Virginia's May monthly meeting entitled Mental Health Crisis Response Systems, a panel discussion. If this is your first time joining us, we host events like this one every month at our monthly meetings. So make sure to subscribe to our newsletter to get information and details about our monthly meetings coming up. Also, if there are any mental health topics that you would like to learn about or engage in a discussion on, let us know in the comment section below or email us at info@nami-nova.org. We're always looking for new and exciting ideas for our monthly meetings. Before we get started, one more quick plug. This upcoming Saturday, May 28th, we're capping our Mental Health Awareness Month event schedule with our annual NAMI Northern Virginia Youth Fest. This event is going to be an in-person event at Cub Run Rec Center in Chantilly from 1 p.m. to 5 p.m. We'll be inviting youth, young adults, and their family members to join us for a really fun event. There's going to be some more information about that in the chat. Please register in advance. Okay, so for this evening's event, currently a person experiencing a mental health crisis is often more likely to interact with a law enforcement officer as a first responder than a medical professional. Individuals with a mental health conditions make up an estimated 44% of those incarcerated in jails and 37% of those incarcerated in prisons, amounting to roughly 2 million people with mental illness being booked into our nation's jails each year. Millions more end up in emergency rooms, ill-equipped to address mental health crises, often waiting hours or days to access care. So tonight, we're going to be having a conversation on Northern Virginia's behavioral health response system as we explore what works, what hasn't worked, and what we envision future response systems will look like. Please allow me to introduce our panel this evening, who are going to help guide us in this conversation. First, we have Lisa Potter, the Director of Diversion Initiatives for Fairfax County. Also joining us tonight, we have Abby May, a licensed professional and certified substance abuse counselor and the current Director of Acute Services for the Fairfax Falls Church Community Services Board. Next, we have joining us from the Fairfax County Police Department, Officer Joseph Schlenz, an instructor for the Law Enforcement Training Unit at the Fairfax County Criminal Justice Training Academy and lead crisis intervention team instructor. And lastly, we have Anna Strasburger, a NAMI Northern Virginia program leader, certified and registered peer recovery specialist, and an active advocate, as well as a board member for the Arlington Community Services Board and Mental Health Committee. Thank you all so much for being here. As we engage with these folks on your screen on this complicated topic, I'm going to encourage everyone to post any questions and comments that you might have in the chat. We'd love to hear from you. Also, like a YouTube specific thing, please be sure to subscribe to our channel here, like the video, and that'll help you find our future content much easier. So to kick off our discussion, I'm actually going to start with Anna. Anna, you're going to sort of represent an individual with a lived experience of dealing with mental health crisis response on this panel. You yourself have admittedly suffered from a mental health crisis. What was your experience like? What has your experience been with local crisis response systems?
So I've had I've had several encounters in mental health crises. So I'll start with one of the first ones, just because of how memorable it was. To give a little background, starting in middle school, it started with like anxiety and depression, nerves. It gradually started to impact my life, my functioning, quality of life more and more, to the point where I was needed to start on medications. That made things worse with what I was dealing with at the time. My depression got a lot worse. I also started getting very wired, high energy, very anxious and agitated all the time. I started self-harming, having suicidal ideations. I'd sometimes get delusions where I would think things or believe things that were not true or not real. And essentially this just kept progressing and progressing. And finally it kind of tipped one day where I had been self-harming a lot. Those around me could see something was really off, and I was in a very dangerous way. I was experiencing what we found out was called a mixed episode. So pretty much I was very depressed, but very energetic and agitated and anxious and feeling electric all at the same time. I was believing things that were not real, And I just like, it was very hard for me to feel like I was like to live, as well as what was going on inside my head. So in addition with those symptoms and experiences, I was self-harming more, starting to do really reckless behavior, and was having suicidal ideation, and I had a plan, which those around me knew. So they were pretty concerned for my safety, as well as those in my immediate area, because at this point I was no longer really lucid and no longer what seemed like myself. Some of this I actually don't even remember myself. So, but what I do remember is I was pacing around, pounding my head like with my hands, because it felt like that was the only way to get things out. And next thing I know, I look down a hallway and see the fire department and some police just standing in the doorway, very tall, very imposing, very intimidating. So while I'm experiencing everything, I also start having a panic attack as well, and start somehow shutting down while also still experiencing what I was having. Also, one of my coping tools at this time was self-harm, even if it was in the moment and very subtle, or what I thought was subtle, which will come back in a minute. So they came in, they asked me to sit down, and they wanted to talk to me. I didn't understand why they were there, why they wanted to talk to me. I was terrified. I was shaking. I remember that. They started looking around, and I was like, why are they looking through my things? Why are they going through my stuff? I still don't understand why they're here. And why people that I knew were not even in the room or just standing off in the background. It was never explained to me. Eventually, it was just told to me that there was concern about my safety and those around me, but there wasn't really much explanation as to why. And I tend to ramble when I'm nervous or kind of panicking, or I'll shut down. And again, I was also experiencing, a version of a manic episode, so high energy at the same time. I was asked to step outside and sit down, and they said they wanted to put me in zip ties for my own safety, which again, didn't make sense to me. And I was sitting down on the curb, everyone up over me, very like dominating, intimidating, threatening things. And I'd had bad experiences with that type of individual in the past for other reasons. So super comforting. And, I was, the trembling and all of that was going even more. At this kind of point, my memory kind of starts getting really fuzzy, because I think, my trauma response just really started blocking things out at this point, especially since I was already kind of in the throes of it. But next thing I knew, they said that we needed to go to a hospital. And again, I didn't really understand why. I remember getting in the ambulance, and at first, just sitting there, it was fine. But in order to self-soothe, I started self-harming without getting too detailed into that. That was noticed. So then I was put into restraints. And it just kind of went downhill from there, because again, I didn't really understand what was going on. I wasn't really told anything. I didn't have anyone with me that I knew or felt safe with. I didn't know what I had did wrong. Like, I just didn't understand what was happening, again, while also dealing with what was going inside, which was terrifying enough as it is. You can probably tell, just kind of like getting into the weeds of it again is very like, I can almost like feel it still. So they did take me for this particular time to one of my local hospitals, which led me to the ER, which was a whole nother set of experience. But that was pretty much one of my first encounters with a crisis response or something of that nature when I was experiencing something. I did have other experiences later, similar or different, but that one sticks out pretty much just because that was one of my first encounters, and I had no idea what was going on really up until I think I was in a unit, and even then I still wasn't really sure what was going on. So it was a pretty traumatic and terrifying experience for sure.
Well, thank you so much for sharing, Anna. I think, obviously this is an example, right, of an outcome, like an adverse outcome, right? One that nobody wants. And there are things that are being done, on a region-wide level, county-wide level, in different organizations to try and make sure that these types of outcomes don't occur, right? which brings me to Joe. You're a CIT training officer for Fairfax County Police Department. Can you maybe, tell the audience a little bit about what crisis intervention team training is, its goals, sort of about your role and what your aim is as the instructor of that course?
Sure. First off, good evening, everybody. Anna, thank you for sharing. It's good to see you again. Anna has presented for our 40-hour CIT class as well. And it's, I will say also before I get started, is what CIT is designed to do and its mission, but NAMI itself is an integral part of that training. A little bit of history that CIT was developed 4 decades ago in Memphis with the Memphis Police Department and the University of Memphis, and NAMI was an integral part in that creation. So having that still remain a part of our training curriculum is very, very important. In this regard, CIT really, in its essence, as training goes, is designed to educate and prepare law enforcement officers to recognize the signs and symptoms of someone experiencing a mental health crisis. There is a communication piece to it. It's sometimes misinterpreted as if that's all it is verbal communication, influence, and active listening, and those are very important components. But there's a collaboration piece that is crucial to it. And that's where another person's perspective is very important in that training. The resources and the collaboration between our Community Services Board, our Sheriff's Office, our courts, magistrates, and outreach with NAMI as well is really what the training is about. It's really a mindset, more than training, so to speak. There is a training component there with the active listening, verbal de-escalation, things like that. But it's a lot of ambassadorship, really, is what the training is. And that's the short answer, but I could go on.
Thanks, Joe. Yeah, I know we'll probably get into the weeds a little bit more when we talk about it, but that's a good picture, good overview of that. So I know CIT is not the only part of and law enforcement in general is not the only piece of crisis response in our area. So I'm going to turn it over I'm going to talk to Abby and Lisa for this one. I think Abby's going to take this one and Lisa might jump in, but could you share a little bit about what our current crisis response system, other than law enforcement, for behavioral health crisis looks like? I know you guys are primarily going to talk about Fairfax County, but I know there's some regional things happening as well. Can you share a little bit about what that looks like now?
Absolutely, and thank you also for having us this evening. So I'll talk a little bit about some of the crisis services that Fairfax Falls Church CSB provides, as well as some of the regional services within our area. So the Merrifield Crisis Response Center is our emergency service that provides 24-hour assessment for anybody that's in a behavioral health, developmental, or substance use crisis in Fairfax County. We take, anybody can walk in at any time and receive an assessment. We see all ages. We have peer recovery specialists that are on site that are helping to talk with individuals as they come in, to share their lived experience, to help them feel comfortable within our facility and understand kind of what the process is. Also, we have, as Joe mentioned, CIT officers, crisis intervention trained law enforcement officers that are both from Fairfax County Police Department, as well as the sheriff, that are there 24 hours a day. And really their role at our facility is to be a part of diversion. So individuals that could potentially be arrested in the community could be diverted to our facility. And those officers are on site, the law enforcement are on site to receive those individuals that are under custody, maybe if they're brought in under an emergency custody order because they're at risk of harming themselves or others and are involuntarily brought into our facility to be evaluated and referred for treatment. So that law enforcement has been on site at the Merrifield Crisis Response Center since 2016, and it's really helped to increase in the community the numbers of individuals that are brought in versus incarcerated. Out of the Merrifield Crisis Response Center, we also have two mobile crisis units that respond out to the community for individuals that are unable or unwilling to come in to seek treatment. Those therapists that respond in the community are able to hospitalize individuals involuntarily if needed, hospitalize voluntarily, as well as help link those individuals with outpatient resources. Our mobile crisis units also provide critical incident response in the community if there's a traumatic event. They also serve as consultants to the police department if there is a hostage negotiation situation in the community as well. And then since we only have 2 mobile units to serve the whole county, they triage their referrals kind of based on risk and responding to those that are more life and safety threats as the top priority, as well as to any law enforcement requests. We also have one of the newest additions to our crisis services that I know we're going to talk about later, kind of the expansion efforts, but we started a co-responder team with law enforcement, which is a CIT trained law enforcement officer, as well as a crisis intervention specialist that are responding to 911 calls in the community. We did a pilot program for that back in May, and then we started the program again in September. And that program is currently running from Wednesday through Sunday from 2 to 11. We have plans to expand that in the future to add additional teams across the county. And again, we're going to talk about that more a little bit later. But one of the parts of the co-responder is also having a behavioral health clinician at the dispatch center. And we had, during our pilot program, we did have a clinician there to help to identify 911 calls that what would be appropriate for the co-responder to respond, as well as to provide information to the field team in the field to help them as they respond. We also have a community response team, which is a team of, again, a crisis intervention specialist and an emergency medical technician. That team is focused primarily on individuals that are frequently calling public safety or calling 911. And that team gets their referrals from public safety. So fire and rescue or police or sheriff would be referring those individuals to the community response team to do follow-up, outreach, case management, to really spend time, which is kind of a different response than mobile crisis, where mobile crisis is just sort of focused on the crisis, where this team is not just focused on the crisis, but providing more follow-up engagement and outreach. We also have a peer support specialist that's a part of that team that responds out with the community response team, which has been really helpful. They have gotten involved, that community response team has gotten involved with a lot of different types of calls, including individuals that maybe need assistance with medical care, medical equipment, kind of basic needs services as well. We also have a detox facility, the Fairfax Detox Center, which focuses on short-term residential services for adults to help them safely detox from alcohol and drugs. Part of the detox diversion, Fairfax County Detox is also detox diversion, which is a mobile team that responds out in the community to divert individuals also from potential arrest and respond with the community and also with law enforcement. They have some limited operation right now, Tuesday through Thursday from 10 to 6. They're available. Then there are 2 mobile crisis teams that are regional that respond 24/7 for crisis intervention and evaluation, and they're contracted by behavioral health and it's not directly operated by Fairfax Falls Church CSB. One of those programs is called REACH, and it's focused on adults and youth with intellectual and developmental disabilities. And then we have the community regional crisis response team that's focused on adults and youth. So they'll be out in the community responding as well. And we're going to talk a little bit later about some of the, again, the expansion efforts, but those teams will eventually be dispatched from the 988 regional call center that's coming online soon. We have a peer overdose response team called PORT, which is certified peer recovery specialists with lived experience with mental health and substance use disorders that also provide outreach and engagement to individuals at high risk of opioid overdose. They are emphasizing a framework of harm reduction and work on helping people with recovery action plans and linking to ongoing support groups. We have Wellness Circle Crisis Stabilization Unit that is directly operated by Fairfax CSB, which is a residential crisis stabilization facility that's 16 beds where individuals can stay up to 21 days. That's for adults that are in acute psychiatric crisis and those with co-occurring substance use disorders. They also provide clinically managed medication and Suboxone detox. We also have Recovery International, which is a newer program that opened in February. It's also a contracted program, and it's a little different. It's a crisis receiving center, which is a little different than crisis stabilization unit. They've actually run into some challenges because it's such a new model in Virginia. There isn't really a license for it in Virginia to run a crisis receiving center. So they haven't really been able to run yet the way they'd like to run. They want to be able to take involuntary as well as voluntary individuals at their facility and have on-site medications, and if necessary, have a restraint and seclusion room. Because there hasn't been that license available, haven't quite been able to operate like that. And they've been working with the state to be able to set that program up. So we're excited about that potential. They're a little different focus than our current crisis stabilization unit, and they're a short stay for about 2 days, 2 to 5 days on average, and really trying to get people stabilized and then return to the community. They're also looking at expanding and adding additional 23-hour beds, up to 16 23-hour beds where people can stay for up to 23 hours to kind of resolve their crisis at the facility. And that's something else that'll eventually be coming. Also, currently, they don't have detox services, but that is something they also want to be able to provide when they're able to have on-site medication. And then we have our Leland House Crisis Stabilization Facility that's just focused on youth. That's also a contracted service and not directly operated by Fairfax CSB, but it's a 45-day youth crisis stabilization and residential program, serves ages 12 to 17. So that's kind of the overview of what the current crisis services are. And we have some other things we want to talk about in terms of expansion, I think, later in the panel.
Yeah, thanks so much, Abby, for sharing. Yeah, it sounds like there's just so many like things already that Fairfax Falls Church CSD, kind of helps when it comes to crisis response. And I know that there's a lot of sort of new plans for things coming in the future. I'm gonna swing it back around to Joe. I think as sort of, I know you're mostly in the academy training now, but as someone sort of with more of that boots on the ground, or at least your ear, hears about boots on the ground on a daily basis. I know that you, train rooms full, 30, 40 law enforcement officials at a time at these crisis intervention team trainings. You work with cadets as well. Can you speak a little bit to like the impact of some of these programs, like the impact of these trainings? Like, what do you hear from officers or other law enforcement that receive this training, and how it affects their work? You mentioned the sort of state of mind aspect of that training. Like, are there differences that are noticeable in those officers in their interactions that they have before having this type of training and afterwards?
Yes. So coincidentally, we just kicked off our class this week today. So day one, Monday, actually just wrapped it up just before this panel started. So we're kicking that off. So it's really exciting. It's a group, varied group of 25 students comprised of the police department, the George Mason Police Department, the Sheriff's Office in Fairfax County, City of Falls Church, Vienna, Town of Herndon, a couple of federal agencies as well as one of our police chaplains, which I'm very excited about, who works for our peer support recovery with the police department under the umbrella of incident support services. So that's what we have today, and we're going through that. Speaking for myself, I went through the class back in 2016. When we started this program of this Memphis model that we have now implemented, I was told to go in the class. I had thought that my communication skills were already effective and I didn't necessarily need to go to the class. I had an open mind about it, but really where the turning point was for me was hearing the real lived stories was the big thing, the perspective piece. And then also that it was not just a Fairfax County endeavor, but a national, international model. So the Albemarle Police Department are really our godfathers as far as our training goes, and they helped us put our training together throughout the state as well as here in Fairfax County. And that's when I really started perking up. And then also within that training that week, we do our practical scenarios. It was there I was able to showcase some of the skills that I had, but what was very apparent to me, having gone through that class personally, was how it bolstered my confidence. It gave me more confidence to actually know the ability that I was able to have confidence in my decision-making as far as when to enact a paperless emergency custody order, linking some of the resources and validating the listening skills that I already had, as well as looking at that empathy piece. I would like to think that I was always considered myself to be a very empathetic person, but what this class was very clear to me was the focus on recovery. Very often in our line of work in law enforcement, we see individuals on their worst day. And that's something that we are constantly faced with. We don't see the other side of an individual who's actually received services and treatment and a different side of somebody. That's something that all the students that go through the class, whether it was myself or as the years have gone on, pick up on that. And that's actually something that I spoke about moments ago in our classes. Many of the things that we're talking about, and probably later on in the panel, about some of the staffing shortages at the hospital, the long wait times in the hospitals. As law enforcement, we're in this difficult place of how do we work through this? The training gives us a nice reminder of why we're doing this, and we can't do it alone, so to speak. So for me, that was one of the big takeaways of going through the class. And I know for a fact with any student that has gone through the class, law enforcement sees that perspective and takes away that perspective more than anything. I don't know if there was another question in there. It was kind of a broad answer to what you asked. Did I hit everything, or did I miss something?
Yeah, beautiful. Yeah, you hit it.
No, yeah, I was just gonna say, Joe, I love that you touched on that personal story piece, because I know that's something that we talk about all the time at NAMI, and that's why we're grateful to get to work with you, as part of the CIT training.
Sorry to interrupt.
No, go ahead.
One thing I forgot to mention, I actually made a note of it here when Lee was actually about to ask me that question. There are times where it's difficult to go through the class as well because of how many of these instances hit us close to home for all of us. It makes us, there's a lot of self-awareness that occurs in the class. And I think in law enforcement, sometimes we don't like addressing those things, because working at Merrifield and interacting with individuals experiencing a crisis, you learn about yourself as well, and you learn about your family and how you work with family, and taking things for granted, and that empathy piece is very, very big in that regard. And that's something that working at Merrifield is something that I definitely picked up on. I know the officers and deputies that work there, recognize that aspect. And I forgot to mention that it's personal for a lot of people. And no matter our state in life or what we do for work, it affects us all in ways like personally and obviously professionally in law enforcement regard. So it can be very challenging at the same time.
Yeah, absolutely. I definitely understand that. And again, that's why those personal stories are so powerful, because we can relate to them. And that brings me back. I'm going to bring it back to Anna. And I know you shared your personal experience, and especially that early experience, and the challenges that you faced in working with law enforcement and with EMS. And I was wondering if you could share just a little bit about, what in particular worked with that experience, what didn't work, or with some of your other experiences with crisis. Were there any positive experiences that you had? And what do you think maybe could have gone better?
Absolutely. So like I mentioned, there was numerous times that I've had the crises, and that earliest one was probably almost over 10 years ago. So it was before lots of these things, I think, got started. So just kind of saying that. So as probably reference from my first story, I feel like, not the communication piece, not being told what was going on, not ensuring my safety and things like that were a big problem. It would probably be easier to say that when it's gone well, that's what's helped, is, when they would get down on my level, whether that was communication style, the active listening, the, affirming what I'm going through, even if it's not acknowledging it or, playing off of it, but just, that I'm going through something while they're still doing what they got to do. Sometimes it could be a body language thing, but really just trying to, see me as a human being and not just, oh God, I have this crazy person in front of me. It also really helped when they would check in about, like what would make you feel safe or how can we make you feel safe right now? Really just bring the element of safety into it, because then I would kind of understand like, okay, well, maybe they're not against me, or maybe like they're not trying to hurt me. And kind of, I feel like those types of things really helped. I will say, as I kind of progressed through the system, I did start encountering people that were trained, and it was a lot better, just because like times where I'd have encounters with the EMS, for example, they were a lot more like active listening and, trying to be more respectful, or like, do you need a blanket, and just, really treating me like a human being, which made a huge difference. And having presented for like some of the CIT classes like Joe's, like I will say, it's very inspiring, some of the questions that they do ask and what you guys teach them, and like really trying to understand our perspective and like it seems like to me, at least the few times that I've done it, like trying to see us again as people, and kind of shifting that mindset. And I feel like that really is just a huge thing that I've seen has been helpful, both in my personal experience and those that I've seen that are still encountering things, especially in our area compared to other areas. So just the approach and the communication, again, like the safety, the body language, that's been helpful. And I'll also say, kind of around when this stuff was becoming new, so I'll give it that, I didn't know there were things like CIT or crisis stabilization units, CSBs, any of that kind of stuff. So had I known about some of those options, that would have also been helpful, or had my family known, so it wasn't like all or nothing or so extreme, or maybe wouldn't have been so traumatic. So the fact that there's those things out there now, especially with peer specialists, because I always feel like hearing that lived experience and that person that's gone through it is so helpful, at least for me. I think that's huge. So I'm happy that that's going on out there.
Thanks, Anna. Oh, Joe, did you have something else to add?
I just wanted to add on to what Anna was saying, that was very important about the communication. And it's something that every single one of us as human beings, we all fear the unknown. And in these instances, when an individual is experiencing a mental health crisis and not knowing what to do, not being sure what the process is, that's something that is impressed upon our students in the class, of explaining the why. Time and safety and, permitting, sometimes there's instances of there's aggression and violence. We don't have the ability to do that. But if we do have the time, explaining the why is very, very important. Like in depth, there's no secrets. There's no surprises. There's been many instances where the officers and deputies that have that work over at Merrifield, we explain the entire process of what's going to happen from the moment that they leave that interview room at Merrifield, going to the hospital, what to expect in the medical clearance, what's going to happen. There's no surprises, and there's a lot of transparency. And Anna talked about the body language, and what I like to call the tone of an interaction is so important. Not only in terms of any aspect of our job, even with a traffic stop, for example, the least of which in a interaction with someone experiencing a mental health crisis. That is very, very important. And for Anna, the one thing I was thinking about when she was talking about her first experience was with the officers that were really tall and imposing in the hallway. That's the challenge that we have, to figure out a way to communicate with all of the distractions that we have, the negative aspects of someone might have a negative experience or have dealt with trauma. I think it's very safe to say that when we respond to individuals in that instance, we should assume that they've had a traumatic incident with law enforcement and treat it in that way, and to impress that culture of safety, so to speak, that Anna was talking about. Like, I'm here to help you. That's something else that we've made very clear. It's like, even when instances that someone needs to be put in handcuffs or zip tie, as in Anna's instance, it's very important to explain why those are going on and that you haven't done anything wrong and you're not under arrest, because that's the other feeling that when you're put in handcuffs, you're going to jail is the perception. And that might not be the case, but explaining the why is very, very important. I just wanted to add that to what Anna was saying.
Absolutely. And I think you both touch on communication, and knowledge is so important in a crisis, and it's so hard to get that during a crisis. So I part of the point of this panel too is we know there's so many resources. A lot of people don't know about CIT. A lot of people don't know about the mobile crisis units. And Abby gave a huge list, and I'm sitting here going, I didn't even know about all of those resources that were available. And so it's so great to have this conversation, to be able to communicate those out. And as Joe, you said, sometimes people have traumatic experiences with police, so maybe that they want to be able to find other options, what other resources are available. So I'm going to shift back to Lisa and Abby again, because I know we talking about the CIT side of things and the law enforcement side. But I know, Abby, you gave a great overview of what resources are available and talked a little bit about what's coming. And I want to dive into that, because I know there's a lot of really great things coming up with our crisis response system. There's a lot of changes coming. And I was wondering, I think Lisa's going to take this one. If you could share a little bit, Lisa, about what's coming up, what's changing with our crisis response system.
Sure. Thank you, Megan. Good evening, everyone. And thank you to my fellow panelists for all the information and experiences that you shared tonight. Just a brief mention of our Diversion First initiative, which is a countywide initiative to divert people with mental illness, substance use disorder, or developmental disability who commit low-level crimes to treatment and supports instead of arrest and incarceration. So some of the programs that Abby mentioned, including the Maryfield Crisis Response Center, was really born out of Diversion First, which kicked off in 2016. In addition to the services that Abby mentioned, there are also certainly community-based treatment, pre-release trial services, specialty dockets, jail-based behavioral health services, reentry, and community-based supports post-release from the Adult Detention Center. So we really tried to build a host of services along a continuum, offering different interventions at different points where folks may interact with people who are involved in the criminal justice system. So we spent a lot of time focusing on from law enforcement encounter forward. And in the past couple of years, we've really started to focus more and more on crisis response and intervening before a crisis escalates or before interaction with the criminal justice system. So that's where there's quite a bit of overlap and certainly some intersection between all of the different initiatives and how they come together. So Abby had mentioned the co-responder expansion. And while there is one team in the community now, there is a plan for expanding as soon as we possibly can. And that plan will include 4 teams that will cover, each team will cover 2 substations or 2 police districts throughout the county. They'll operate during peak hours. Abby mentioned that in addition to the crisis intervention specialist and the CIT trained officer, we'll also have crisis intervention specialists who can pair with peer recovery specialists to do some follow-up calls in the community. I know folks are often interested in, so after a crisis, then what happens? So the more we can have resources, support services for people to do follow-up after a crisis, we hope that will help to contribute to success and also people receiving the services that they need. The teams right now are riding in the same vehicle, and as the teams start to tool back up, they will be riding together in unmarked vehicles to try to have more of a response that isn't so, lights and sirens coming into someone's neighborhood and You know, hopefully at some point, maybe soft uniforms and things that are just a little more approachable for community members who might receive this type of response. Because the community response team is going out on calls that have come directly to the 911 call center. So someone is in the midst of a crisis in that moment, and the team is really committed to making sure they're providing the most approachable response they can. Also, the teams are working really closely together to cross-train. I will say that the officers who are part of the team right now are so uniquely qualified to do this work. And they've done such an incredible, amazing job. And it's something that they have a tremendous amount of passion for. And the crisis intervention specialists certainly bring their own specialized training. So we really feel like it's a team of people who are uniquely qualified to do this type of work. And we're committed to making sure that those are the teams that continue to operate in the community. There's also a number of efforts, and the co-responder team is certainly aligned with the statewide Marcus Alert system. And I know people have a lot of questions about the Marcus Alert, and understandably so. The Marcus Alert was, it's a law that was enacted out of the 2020 General Assembly. And it's actually the Marcus David Peters Act. And it's named for a young Black biology teacher who was killed by the Richmond police in 2018 during a mental health crisis. So the crux of the legislation is that it requires 911, law enforcement, behavioral health agencies to work together to better respond to behavioral health crises situations in the community. So there's really a phased approach to how this is going to happen. And there are 5 jurisdictions who were part of phase 1 Marcus Alert implementation. And in our locality, in our region, it was Prince William. So Prince William started their Marcus Alert efforts, their system in, I believe, December of 2021. And the legislation requires that the largest jurisdiction in each region be part of phase 2. So we know that Fairfax County will be part of phase 2, which starts July of 2023. Then all of the rest of the jurisdictions will be phased in over time up until 2028. So there are various components to the Marcus Alert, and we're lucky that Prince William went first. So we're hoping to get a lot of lessons learned from how things are working there. And they've done a wonderful job with their system so far. And part of the Marcus Alert legislation involves a call center. So you're hearing more and more about regional call centers, and also that intersection between the call centers and the new 988 number. So 988 is a new designation code, dialing code that operates through the existing National Suicide Prevention Lifeline Network. And what will happen is when folks call 988, those calls will go directly to the regional call center. Right now, the National Suicide Prevention Line is operated in over 200 different areas. PRS is the vendor for Northern Virginia. So PRS is going to be the operator of the regional call center /988. So right now, if I call 988, it may depend on my phone carrier. If I have some of the major carriers, they're already using 988. But as of July 16th, everyone nationally will be required, all phone carriers will be required to use 988. So in Virginia, we're fortunate to have this Marcus Alert, which includes the regional call center, because that's where those 988 calls will go. So it will change a little bit on July 16th because all carriers will cover 988. But right now, if you call the National Suicide Prevention Line, that call goes to a local PRS call taker. So the great thing about that is that the PRS call takers are going to be able to serve a variety of different functions. So they may help somebody who is calling in a crisis and needs someone to talk to. They may be able to help provide resources. And this really is such a game changer because so often people call 911 because they don't know who else to call. And especially if it's 2 o'clock in the morning or off hours, the person that they may have called a community services board, they may or may not have services during those hours, depending on where the person lives. So it's really an opportunity to completely change how people are able to reach out for help in the midst of a crisis. So we're really excited about that. And as Abby mentioned, the plan is for the regional call centers to also be able to dispatch some of the mobile crisis teams like REACH and CR2. So that's going to be an incredible systems change throughout the state and the region. And it's really going to be phased in over the next couple of years. So as of now, if you call 988, you'll get PRS. That will continue, and PRS will just continue to expand the services that they offer. Also, Abby mentioned Recovery International, and that center is really working to become more of that crisis receiving center. And it follows a national model called Crisis Now, which is a best practice model. And basically, it involves someone to call, someone to respond, and somewhere to go. So the someone to call would be 988. The someone to respond would be mobile crisis, co-responder teams, folks that are able to respond to crisis in the community, and somewhere to go, hopefully the crisis receiving center where people can stay short term or even 23 hours once that component of the program is built out over time. So I'll take a pause there and see if there are any questions or anything Abby wants to add to that.
I think you did a great job, Lisa. I think just one thing I would add is that, you know, when looking to expand our continuum of crisis services, the different things that Lisa is talking about with the call center and with the 23-hour program that I had mentioned earlier at Recovery International, there's a significant portion of people that are able to resolve their crisis without necessarily having a response to their home, not necessarily having law enforcement or public safety show up to their home. If they had somebody that was on the phone that could focus on their behavioral health crisis on the phone and help de-escalate and provide resources, they may be able to, you know, de-escalate the situation and provide referrals where they could get follow-up care rather than having a law enforcement response. So some of these efforts with the regional call center, with the 23-hour programs, we're also looking to add a 23-hour program at the Merrifield Crisis Response Center. We've been working on trying to start a program there as well. And, you know, there's a certain percentage of individuals that are able to, within 23 hours, you know, maybe come in, have some peer support, counseling, have some, you know, crisis intervention, maybe have medication if necessary, maybe have a rest. There, if we have enough people, have a small group that they could have on site, get access to some food, you know, some activities while they're there, and then able to go home without having to go to an inpatient setting. And so having some of those alternatives, whether it's, you know, over the phone or the 23-hour program that individuals could have access to, I think will be a great resource.
Awesome. Thank you, Abby and Lisa. It's so great to hear. I know you mentioned Marcus Lawyer is really about the collaboration between all aspects. And, you know, we heard earlier about how some of that's already happening in our region, which is fantastic. And there's so many plans to continue that. It's just so great to hear all that's happening in this region and both that already exists and what's coming. Lisa, just I wanted to check. I know you briefly mentioned Marcus Lawyer, and if I am correct, there's a meeting later this week if people want to learn more. Could you share a little bit about that quickly?
Absolutely. Thanks, Megan. We do have our Diversion for Stakeholders meeting coming up in 2 days on Wednesday, May 25th. It's from 7 to 8:30. And I believe Megan is going to put a registration link in the chat. If you are interested in attending, you are more than welcome. Anyone is welcome to attend. Registration is required. And once you register, it's a Zoom meeting. Once you register, you'll receive a link to sign into the meeting. And the agenda will involve some updates on some of the programs like the mental health docket, medication-assisted treatment within the Adult Detention Center, an update on the co-responder team, and then we're going to have a featured presentation on the Marcus Alert System. Following the presentations, we're going to have some breakout sessions so people can have an opportunity to provide input and discuss some of what they heard and any other thoughts that they'd like to share. So we encourage anyone who is interested in attending to please do so. If you are interested in the material and you're not able to attend, we are going to record the meeting, and that recording will be posted on our Diversion First website, which you can get to easily through the Fairfax County main website, or honestly, if you type in Diversion First in Google, the website will come up pretty quickly.
Thank you, Lisa. I did include the link to that in the chat. If anyone wants to register for that meeting, I will be there. I'm excited to learn more about Marcus Alert. So I want to take a pause and just give our attendees time to put some questions in the chat. If you have questions for any of our panelists, we do have a few more topics to discuss, but I want to pause and let anybody ask some questions. I did see a comment in the chat just in connection with that. As Abby said, sort of having that phone call and being able to de-escalate, they said, oops, let me put up, getting that connection to be able to talk to someone is definitely a difference between life and death in some cases. I think that's a very good point, that sometimes that de-escalation call can make a big difference. All right, I did see a question pop up in a chat. Somebody asked, so there's a concern that is there a concern that people are being treated unequally? Some people get diversion first, mobile crisis, and some do not. I know Lisa and Abby, can you maybe talk about how people get access to which of those services? I can repeat the question if that'd be helpful.
Yeah, please.
Sorry, my mute took a second to come off. I think it was about how some people get access to diversion first mobile crisis versus others.
Yeah, so is there a concern that people are getting treated unequally? Some people get access to those services, some, maybe get law enforcement as the first responder, I guess. Sort of how does that happen?
Yeah, so, I mentioned earlier that basically we have 2 mobile crisis units that cover all of Fairfax County, and then we have the co-responder team. And so our mobile crisis units, one of them runs 8 a.m. to midnight. We have a second team right now. Our second mobile crisis team is just running on Monday and Tuesdays. And then we have our co-responder team running on Wednesday, Thursday, Fridays, and through the weekend. So, and the mobile crisis team that's on Mondays and Tuesdays, the second team is 12 to 9. And I think I mentioned earlier that the co-responder team is 2 to 11 on Wednesday through Sunday. So there is limited coverage in terms of 24-hour response for mobile crisis teams across the county. I know we mentioned earlier the expansion of our community response team, and our plan is to have 4 teams, like Lisa mentioned, that cover 2 substations across the county, and those would be similar hours from 2 to 11. And so I think our future expansion will be able to provide that service much more often across the county. But currently what happens is it's basically individuals' calls are triaged based on risk. And, the mobile crisis team tries to respond as soon as possible and prioritizing individuals that are life-threatening as the first response. And oftentimes law enforcement is involved in those situations. So mobile crisis will be called to the community by law enforcement that are out with that individual, that they're suicidal, homicidal, and at risk, and request our mobile crisis team to respond. So if they're available during the hours that those units run, that mobile team responds. If they're not, then that individual can be brought into the Merrifield Crisis Response Center, and law enforcement often does that. I don't know if, Joe, you want to comment on that in terms of the hours when mobile crisis is not available.
So in those instances, ultimately it's up to obviously each circumstance is going to be different, but for individual officers' discretion to make a thorough mental health investigation, as we call it in the class. And going back to that mission, obviously we're talking about recognizing the signs and symptoms, but we're also trying to look for those long-term solutions. And that's where the linking of resources come into play. So if I'm working a midnight shift and I've gone through this 40-hour CIT class, I'm trained in crisis intervention, I respond to that event, I speak to family members, I talk to the individual that's involved, and I make that determination whether this person needs to be placed under emergency custody and brought to Merrifield. That in the code, the Virginia code for that, in case anybody was curious, is ultimately that this person has a underlying mental illness, and because of that mental illness, there is a substantial likelihood that this person may cause serious harm to themselves, others, or inability to care, and are unwilling or unable to seek voluntary treatment. So an officer on scene has to make that determination. The state code is that law enforcement officer is the only person to make that determination out in the field. Any citizen in the state can obtain a paper ECO from a magistrate petition, but out in the field, a law enforcement officer is the only one to make that determination. It's quite a burden to have, actually, because we're not social workers, so to speak. This training assists in that endeavor because we are able to determine that clearly there's a mental health component going on here. Clearly this person is in need of treatment, but ultimately it's up to the clinician that is assigned to Merrifield, that is a certified pre-screener, to make that decision whether that person's detained. So that's where that collaboration comes into play. And I think it's interesting to note that I think that discussions might turn toward whether law enforcement is the best to respond. And I think that that's the things that we're looking at right now. But culturally speaking, for the last few decades, the law enforcement are the first responders. Now we're moving in that direction of the co-responder, but ultimately there's that safety component of making sure that the community stays safe, the family members, the personnel at the hospital. And in those instances, there may potentially be acts of violence, but this is an instance where, despite our best efforts, we want to help people and we want people to get treatment and get better. And it's a difficult position to be in, particularly if there's a level of violence or aggression, very, very difficult cases. And ultimately it's at officer's discretion to make the determination whether diversion is the best option in that instance, and bring that individual to Merrifield for an assessment.
Yeah, absolutely. As you said, Joe, that's a very tough decision to make, and tough that it falls on law enforcement all the time, which, is why it's great to hear about some of these co-responder models that can provide additional support in that sense. I do want to just remind people, if you have any questions, feel free to put them in the chat, but I want to shift the conversation a little bit because it's sort of been brought up, but we haven't dived into it too much. So NAMI Northern Virginia obviously serves people with living with mental health conditions. We also serve family members. We know family members are, serve as caregivers, support systems to individuals living with mental health conditions. And that's an important part of somebody's recovery. So I want to talk a little bit about sort of the family perspective. And I'm actually going to bring it back to Anna for a second to share a little bit first. Anna, in any of your sort of cases with crisis response, was a family member involved in that? And was that helpful? Did they know what to do? How did that experience happen with maybe a family member, any of those experiences?
So for me, they were involved some of the time, just certain family members. I will say, since before some of these programs, they were around, but they definitely didn't know what to do. They had never encountered the mental health system or anything like that before. So I think they started with calling like our insurance company or 911 or whatever it is, like however severe it was at that time. So that was, and so sometimes they were involved depending on who I was with at the time. They weren't always involved. I also know that I have another family member who had a crisis that our family called them on. And I think that was a 911 because it was the fire department who responded. Again, they had no idea what was going on with that family member and were just sort of panicking. The first thing they could think of was the 911. And kind of after it was all said and done, you know, probably one of the alternative programs that we're talking about here probably would have been more effective or more helpful for this member of the family. So yeah, it usually just came down to they had no idea what to do. So it was either our health insurance or 911.
Thanks, Anna. And that sort of gets me into sort of the next question for maybe Abby or Lisa, and maybe Joe could jump in too at some point. But so if you are a family member, if you have a loved one who is exhibiting signs of a crisis, you know, what is that first step? I know, Abby, you talked about all of these amazing resources. How does somebody know which of those to go to, how to get connected with those? What is sort of that first step for somebody to take? I know 911 is always an option, but, you know, are there other things that family members can do?
Absolutely. I mean, I think depending on the situation, obviously, you know, if there's an imminent need for, you know, if it's a health and safety, life-threatening event, it's calling 911 for that immediate response. But if there's some time and you need some, you know, are able to reach out to our emergency services, the Merrifield Crisis Response Center is a great resource to be able to call and to consult with a crisis intervention specialist over the phone and specifically talk about what's going on, what's happening with the crisis, and discuss resources and options. Whether that's, you know, depending on the situation, whether that is mobile crisis responding, whether that's coming into Merrifield, whether the person should go straight to an emergency department. If it's an involuntary, somebody needs to be hospitalized against their will, explaining that process and getting educated and understanding what that process looks like and how that would work. Talking about some of the other resources that I mentioned today in terms of the crisis stabilization facilities. So I think calling Merrifield and consulting is a great first step. This regional call center, when that is up and running, that's also another option when that launches, to be able to call the 988 number or call directly to the regional crisis line and be able to consult with them. To, if the person who's in crisis is willing to talk to somebody directly, they can also call Merrifield and speak to somebody at our facility. Certainly at any time, if somebody is willing to come in, a family member can bring that person into Merrifield. And Lisa, if you had anything to add.
I think you covered so much, Abby, and so much important information, and that consultation part I think is so important. The clinicians at Merrifield do quite a bit of consultation for family members who call, and it is so specific sometimes to a situation that they can really help guide each person based on what's going on with that family or individual. Also wanted to mention that people can ask for a CIT trained officer if they do call 911. And one other piece is that the Marcus alert does include a component for a voluntary database, and each locality has flexibility and how they want to implement that and what that involves. But Fairfax implemented something about a year ago called a personal health profile, where folks are able to add information that first responders would see when they do respond to a home. So that may be helpful just in general for people to have, whether it be for family members or just any information that you'd want a first responder to have when they come to your home.
Thanks, Lisa. And I appreciate that you mentioned that you can request a CIT trained officer. I think a lot of people maybe don't realize that you can do that. And I don't know, I guess, Joe, is it guaranteed you can get a CIT trained officer, or what does that look like?
So to illustrate that, in Fairfax County, roughly 40% of our officers are trained. So you're getting 24/7 coverage. If there's, on average, there's probably between 3 and 5 officers that are trained in crisis intervention on each squad. So we have, well, currently 3 shifts, so a morning, an evening, and a midnight shift. Unless that officer is already on a case at the hospital or handling another event, there is a very high probability that you will get a crisis intervention trained officer. Though some circumstances that might not be the case, but if it's requested and one is available, and a person is going to get one.
That's great to hear. And Joe, I have another question for you, sort of coming back to sort of that family perspective. I know a part of CIT is hearing from family members in addition to those personal experiences. Can you talk a little bit about the family involvement in CIT and why is that an important aspect, dealing with the family members?
So as far as the family's involvement, speaking from personal experience or in professional experience, nobody knows that individual more than the family, so to speak, not only in terms of support, but also triggers and things that work and things that don't work. And those are things that when I've done the presentations for families with children with autism or intellectual disabilities, to communicate that to dispatchers prior to police arrival. Let the dispatcher know what works. It sounds simple and not very important, but favorite foods, things they like doing. I mean, those are all things that me as an officer, I'm going to use that. And I'm going to try to find that hook by talking about those things if I'm able to do that. And family is the first step. Family is also the first step in terms of assisting that individual through treatment if need be, and supporting that family member. So that's focusing on that front end, working again to the education piece and those long-term potential solutions. Family is integral to that. On the same token though, for me to be objective and fair, if I'm doing my mental health investigation, I also have to take things that families say with a grain of salt sometimes. Can't speak for Anna herself and her experiences with her family, but for individuals that we all have families and we all know that there's something that's lost in communication or that's simply not true or misinterpreted. And as a law enforcement officer, I have to put all that into account, everybody's perspective, but family is very, very important to make that assessment with those triggers and knowing what works and making a plan together and making it very clear on even in terms of what happens during an emergency custody order and what's going to happen at Merrifield. So there's that education piece that the family hopefully will use later on.
Thank you, Joe. Definitely an important piece for sure. I did see a question pop up in the chat. I think that's a quick one for Lisa or Abby. When will the other counties get phased in for residents to be able to use 988?
So my understanding is that 988 is federally mandated for July 16th. So everyone on July 16th, if not before, will be able to call 988 and have that. In our locality, it'll be the regional call center. In other parts of the country, it may be the National Suicide Prevention Hotline. But that 988 number will be active and live by July 16th at the latest.
All right. So I think we're going to switch gears again. We've been talking a lot about, responding to a crisis situation, like an acute crisis situation. We've talked about like pre-intervention, planning for, intervening before any crisis happens. But I know just from speaking with Joe at the CIT trainings, from hearing a bit of Anna's story, sometimes crisis can be reoccurring. Sometimes intervention is required in the meantime. So I think if we could just talk about sort of like between crises, things that have happened, maybe different resources that are available in those types of situations. So I'm going to start with Anna. You've talked about experiencing multiple crises. What kind of support did you receive after or in between experiencing a crisis, or after or in between a hospitalization or something like that?
So almost all of them resulted in the hospitalization. Afterwards, it was trying to work with doctors as kind of like a treatment plan or a discharge treatment plan, which ideally would have been like an intensive outpatient program, a partial hospitalization program, but it was originally just trying to find, me doctors and therapists to kind of support that treatment moving forward. After a time that kind of became a bit challenging, especially with the insurance. I was still on my parents' insurance at the time. So kind of as I was progressing through my years of this, eventually we finally learned about, my dad actually learned about the CSBs and their support services through NAMI Family Support Group, actually. And so I think it was one of my hospitalizations that was also a particularly bad one. We heard about this. And so with that help, that's what started kind of that same day access and that intake process with the CSB. And since that was kind of like a wraparound service and kind of helped all things, that really kind of helped me kind of get on the track or to a point where I was stable enough to kind of make progress. I mean, again, there were still hospitalizations and things, but they got less and less severe, more in between, or we knew more of resources or what to do at this point, what to look for, what warning signs. So it got less scary as I went on. Also between at different points, I would have, different peer support groups, those types of things that would support me, sometimes family. It really just kind of depended on that situation. But again, the idea was in between hospitalizations, I was trying to have various supports, professionally support community to kind of maintain and stabilize.
Yes, it sounds like, lots of different avenues from, sort of like a community-based education level to direct support for you individually, and then also that family support piece, right, can be huge. So moving to either Lisa or Abby, I know you all mentioned, Anna just mentioned different things that the CSB provides for, people sort of in between crises. And I know earlier you're talking about how the community response team, that's part of sort of their directives is to provide support in between or to like help people sort of direct them to care in between. What happens once an individual goes through this like system? What does support look like for them? If you could just talk a little bit more about that in between period after they've gone through emergency services.
So when they come into Merrifield, before an individual leaves, we're trying to put together a safety plan. So in a crisis plan. So, depending on what level of service they need, and we're always looking for the least restrictive alternative, so to avoid hospitalization when at all possible. So trying to have a discharge plan, so to speak, of where they're going to follow up. What's the next step? Whether it's an outpatient service. I mean, the Community Service Board, Fairfax, is lucky to have a broad range of services that we can offer on the outpatient, partial hospitalization, outpatient programs, both for behavioral health, intellectual and developmental disabilities, as well as substance use. So trying to make that direct connection, we have a same day access, which is basically the entry point for services at the Merrifield Crisis Response Center. So oftentimes when people come into Merrifield and are seen in a crisis, if they're not needing to go somewhere right away, they could be seen on our same day access program that same day. Which is our kind of entry and referral department. It's the front door, so to speak, of the CSB, and get their assessment and then get linked up with a follow-up appointment. And that could be in one of the outpatient programs. We also have a range of residential programs, like I mentioned, the crisis stabilization units, but we also have substance use and co-occurring residential programs, as well as residential programs for developmental disabilities and behavioral health. So, and those require some entry into our system and case managers to being assigned and follow up to be able to access those services. But with any crisis, we're trying to have a plan before that person leaves in terms of follow-up and care coordination. I think one of the biggest challenges is people don't always follow that plan, right? So something else comes up, they're not able to follow the crisis plan, they have another crisis. And so, depending on what Anna was saying in terms of insurance, that's another thing we're looking at. Is it best to refer to the private sector? Is it somebody that's going to come through the community services board, looking at their access to resources and what's available and trying to help coordinate that care. One of the things that we noticed is when people are involuntarily hospitalized, there were a number of individuals that were coming out of the hospital, being discharged, then not following up with care or being linked with care, and then ending up right back in a crisis and back in the hospital. So we, a couple of years ago, brought in a care coordinator, and that person's specific job is to follow up with individuals that are involuntarily hospitalized and try to provide outreach after they get out of the hospital in terms of follow-up care. Did you go to your appointment? What do you need in terms of services? Provide outreach and engagement and try to coordinate to try to link that person with the follow-up care. You mentioned the community response team. So they're specifically focused on those individuals that are often calling 911. And most often, a lot of those individuals don't want treatment, or they don't think they have an issue. And so that team is really working over time to build that relationship. And that's where the peer support services are so helpful. And the team has really seen the value in having peer support out with them in the community to try to engage the individuals and try to help get their foot in the door to be open to some services. And so some of those, individuals they're working with can take years to try to engage in services, and a lot of follow-up and outreach to connect to those individuals. I think that also, Lisa mentioned earlier that when we expand the co-responder team with law enforcement, we're looking to have an additional team that's specifically crisis intervention specialists and peer support. And that team would follow up on referrals from co-responder. So if the co-responder had been out on a behavioral health crisis the night before, they could send a referral to the follow-up team that would then follow up and see, did they follow through with the resources that were offered? Did they need additional assistance? And not just being a response that's crisis to crisis to crisis.
Oh, thank you so much. Yeah, Joe, from a law enforcement perspective, right? I know CIT, you mentioned it's kind of like a frame of mind. It's more than just this training and responding to individual calls. I've heard stories of responding to crisis calls multiple times, at the same residence, like that being an occurrence. It sounds like you were describing CIT as almost like an ambassadorship, program as well. This collaboration between law enforcement, family advocates, and other community stakeholders. Could you explain why you think like that is significant and how, that may help with that sort of, touching the community in between crises?
Yes. So the collaborative aspect of the training is obviously there with our classes that are structured into the curriculum. We train side by side with our clinical partners, whether it's a clinical states block with your psychological states, whether it's active listening, whether it's the mental health law in Virginia. There's that collaborative aspect with the clinicians. I think the visuals of a uniformed officer, particularly I'll use Merrifield as an example since the co-responder is a more recent development, but sitting in an interview room with an individual who is either who walked in or brought in by another officer from the field in an interview room and maybe has not been there before. But I think a uniformed officer that's assigned there has the potential of making a really long-lasting impression. And again, setting that tone and explaining what the process is about and the education piece. So that's something that we have ingrained in us, the officers and deputies that are working there, and that simplicity of introducing ourselves and getting the person's name and what brought that person there. And there's no pressure to speak or anything like that. So once we've established that rapport or attempted to establish that rapport, in comes a clinician. There's been instances when I've worked at Merrifield that I've introduced clinicians coming in and clinicians have introduced me. And that's where I think that long lasting effect kind of takes place there. Being assigned to Merrifield, I was able to interact with individuals that I may have sat with at the hospital may have had an altered mental state that particular day and saw the individual differently, actually having a conversation and talking about that instance or being apologetic about that instance and reassuring that person that there was nothing personal in that interaction. A lot of officers in the field don't get that. So that follow-up, that co-responder model sounds fantastic, because there's a similar aspect with an initiative that our police department is taking with this. It's essentially community policing, so to speak, but actually interacting with individuals who just getting to know them in their neighborhood, essentially. That's something that our chief has been very, very clear on. I think from a mental health perspective, that would be interesting to look at too, of actually talking to someone when it's not a crisis and checking in on somebody. And that's something that I think would be great moving forward.
Thanks, Joe. Thank you. Everyone knows, I know it's getting close to 8:30, so we're gonna, start to wrap up. I want to thank you all. This has been a great discussion. It's so great to hear again all that's happening already, all that's coming, and know that there are people continuing to work on these efforts to make our crisis response system better every day. I think this is hopefully really helpful to our community and just sort of spreading that knowledge and educating our community about what exists and what's coming. Just sort of as we're wrapping up, I wanted to ask one more sort of wrap up question. You are all involved in this crisis response system in one way or another, whether it's a strategic implementation or advocacy perspective. So after our discussion today, what is one key takeaway that you'd like our audience to get from being here tonight? And I'm going to switch us over to gallery views so that people can jump in as they see fit. What's one key takeaway you'd like people to leave here with?
I'll kick it off as far as a takeaway. If I could put it in one word, obviously it would be collaboration is the big takeaway. But I also think that, and as a police officer, I can tell you for a fact in any endeavor, least of which mental health, we can't do it alone. So it's all assistance from families, it's assistance from the resources, the community outreach, the education piece, our partners at the Community Services Board, NAMI. That's the important thing. This is not something that a police department can handle on its own. And it's not something that the Community Services Board can handle on its own at this time. I think, wouldn't it be wonderful if there'd be a time where, there could be an instance where law enforcement might be out of the equation entirely, but it's just it might not be that case. This is kind of like something that, again, decades of cultural shift, really, with first responders handling mental health calls. And I think it's moving in a positive direction, but we can't do it by ourselves. So collaboration is the big takeaway.
I think that's well said, Joe. I think I would just add that a takeaway being to reach out, to reach out for help, to reach out for consultation, whether it's calling the 988 number, the regional call center, Maryfield Crisis Response Center, reach out and to call, to consult, to let us help you with resources and options, and to not hesitate to do that.
And I'll just add that there has been a good deal of progress statewide, regionally, and locally in the past couple of years, and we still have a ways to go. And I think everyone who is involved in these efforts certainly at the county leadership level is 100% committed to making sure that we continue to assess for gaps, that we continue to fill those gaps. Abby's example of, we noticed that people were maybe falling through the cracks at certain points after hospital discharge. So now there's a discharge coordinator. So we're going to continue to look at the data to see what's working and continue to build and enhance different services to make sure that we can provide as much as possible in the community. which also sort of ties back to the question of equity that came up earlier. And I think it's fair to say that, yeah, that is something that we do have a concern about. And that's why we continue to try to have a layered approach to offering services in the community. And just to reiterate what Abby said about please reach out. Please know that there are resources, there are people who will help in the community, and lots of folks who are willing to listen. So keep reaching out, and also keep providing feedback. It's so helpful for us to hear what's working well and where there needs to be some improvement. So appreciate everyone's input.
I guess I agree with my co-panelists, with everything. I'll also add, at like the advocacy portion, and again, reaching out, just from my starting and volunteering on kind of the board or committee side and seeing how it's all put. I definitely see that they're needing, that there's trying a lot, but I also have learned how much goes into implementing some of these things and everything that goes behind it. But it gives me hope anyway, just to know that even if things are not implemented yet, we're trying to find ways. They're listening to people. And I know just in the time since I've been in the mental health community and I started experiencing stuff, there's been drastic improvements. And that's been about 10 to 15 years. So it's nice, at least for me, to see, even though there's, of course, still cracks and problems here and there. I think that, there's more improvement. The word's out there more, and the more people speak up and reach out, advocate, reach out for help, the more that those needs can, kind of rise. So I'm hopeful in that regard. And again, just kind of, I am just hopeful and piggybacking off everything everyone else said. So.
Awesome. Absolutely. Yeah, I'll say by no means is this the end of the conversation, but we appreciate all of the insight given today. We know this is a continuing advocacy effort. As I shared the diversion first meeting, if anyone wants to participate in that, that's a great way to start getting involved. Feel free to reach out to us at NAMI Northern Virginia if you'd like to find other ways to get involved as we continue to reimagine crisis and improve this system in our region. Thank you again to all of our panelists for all of your expertise and sharing your personal experiences. And I hope everyone else has a great rest of their evening. Thank you, everyone.